from the Sinai App Lab. I'm actually the Population Health Coordinator for HealthPROMISE, and I want to welcome you all this evening to our webinar series, where we'll be talking on the quality improvements and quality measures for IBD. I want to thank you all for joining us this evening, and with me here I have Dr. Thomas Ullman, who is one of the IBD physicians here at Mount Sinai, and he will be speaking to us today. So before I will hand over to Dr. Ullman, I just wanted to go over a few things and talk about the new developments and happenings for the HealthPROMISE app. Now, if you could look at your screen, I believe each and every one of you are seeing me at the moment, are seeing the screen at the moment. We have the new HealthPROMISE 1.5 that is coming up. Now, we made some changes, and we want to appreciate each and every one of you for the feedback you have given us. It is with the feedback we got, we are able to make the changes to better serve you. Now, we have improved password functionality. We see that most of the patients are having the problem with forgotten password. So with the new HealthPROMISE 1.5, we created a system where you can set the password yourself. In the event, you will always remember what you put in so as to solve that issue. Now we have a better notification. We have linked to physician-approved health education content. Now what that means is, apart from going in to enter your symptoms and how you feel every 2 weeks, we have created a system where you could learn more. So it saves you time of going to Google to look for things related to IBD. We have embedded an education format for everything related to IBD in the HealthPROMISE app. In other words, you can go to your app and learn more about your conditions without going online. Now we have an improved dashboard, and very importantly, we have the drop-down menu option. So what this means is it saves us the time of dragging, which we have been using in the previous app. With the new version, you can just click, drop down, and enter your symptoms to make it easier. Now, we also have the access to the web version. So outside your phone and your tablets, HealthPROMISE is going live on the web, meaning you could sit at home on your computer and you could log into the HealthPROMISE app directly. We also have the monthly webinars, which will be taking place just like the one we're having now. So this is coming up at the first Monday of every month. So this, in addition to other features, are what we'll be seeing in the new HealthPROMISE 1.5 version. Now, if you look at your screen, we have 3 screenshots of the new version of HealthPROMISE 1.5. We want to believe that as we go on, we will get your feedbacks about it, and then we'll make it better as we move along. Now, the next phase of our trial. We have finished the recruitment, and as most of you know, we want to thank you for always going into the app at least once in 2 weeks. But the next phase of the trial is the patient report will be handed to you at your office. Now, most of you might have already begun to experience this, but for most of us who have not yet, please be aware, and we just want to notify you that when you come to your next visit, your patient report card will be handed to you. Now, what we want you to do with this is, we have taken the time to pass out every score you have entered in the HealthPROMISE app, and we have sat down with your physician to discuss it. So please, when you have your report card and it's given to you in the clinic, we want you to be able to sit with your physician and then discuss your symptoms and then your checklist of care. Now, the next slide. This is a sample of the patient's report. On the right-hand side, it shows your recent symptom score, which is what we are all used to. From 10 to 30 is good, 31 to 50 is fair, and above 50 is worse. So lower is good, and higher is bad. But the thing is, we all notice that most of us are already doing well. But if you look at the left-hand side, you will notice we have what they call the checklist of care. Now, what this does is we want a situation where at least every of our patients will have 80% of this checklist of care met. So we are not only looking at the quality of life, we are also looking at the checklist of care. So even if most of us are already doing all right symptom-wise, we want a situation where our physician, together with you as a patient, can discuss this checklist of care features. So this is a sample of the report that will be given to you at your next office visit. When you have this report, please kindly look at the checklist of care, and you will see the quality indicators that are all listed as unmet or don't know. Those are the quality indicators which you need to discuss with your physician, and then he needs to update them on the physician panel. With this being said, Dr. Thomas Ullman is going to come in to explain more of these quality indicators which are listed in the checklist of care and how important they are in maintaining our IBD. I will be handing over to Dr. Thomas Ullman now. The lines are going to remain muted, but we are going to unmute them after he has finished his discussion to give you a chance to ask questions. Now, please note that when the lines are unmuted and you want to ask questions, kindly do not mention your name. We're trying to be as anonymous as we can. I'll be handing over to Dr. Thomas Ullman now. Thank you.
Hi. So this is Tom, and I'm happy to have you all here today, and I really want to congratulate all of you on all these great, all the great progress that we've been able to make so far with the HealthPROMISE, IBD Promise apps. And thank you very much for your voluntary participation in this effort. We're really hoping that this is going to make a difference. The background of all of this is this concept of quality measures and quality improvement in IBD. And really, you know, quality is a very hard thing, believe it or not, to define. And what quality means in healthcare right now is really a great measure of uncertainty. We don't particularly know how to measure in a number of complex diseases what constitutes high quality versus lower quality care. And then we have that kind of definition of quality that's out there. And we also have the definition of quality that's used by industrial engineers as best manifested by the car industry and in particular the Japanese car makers who really sought out and I don't want to say perfected, but really were just such expert marksmen really in developing the concept of quality in manufacturing. And this was done throughout the 50s, 60s, and 70s. And I don't need to go into the history of it because mostly I've forgotten many of the names. But the whole Toyota quality type of endeavor has really taken off and has now been applied in a number of different industries and not even in manufacturing. What we're trying to do, we're trying to get our arms around, and you guys are a part of this, is improving quality in healthcare. And this is a very difficult challenge potentially in complex diseases like the inflammatory bowel diseases. We're going to go through a whole bunch of things. And our learning objectives today for our discussion, and there'll be plenty of time for Q&A. I hopefully won't break too far into the NCAA tournament that's on later. Our learning objectives are going to be to define quality measurement and improvement in the IBD setting, to highlight the benefit of quality improvement initiatives in medicine, review variation in care in IBD, indicating the need for quality improvement activities, review ongoing QI initiatives in IBD, and to review the caveats and encouraging signs that are out there and how we're making progress. And it's really you guys who are making the progress, and we're just interpreting the data that you provide. So thanks very much for that. So what is quality? So Dr. Chasson, who has been with New York State Department of Health and was previously with the Institute of Medicine and still is, defined quality as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. That's a bit of a mouthful, and there are a whole lot of buzzwords that are in there, but really the concept is what can we do and what should we be doing on a regular and consistent basis that will improve the health outcomes of you guys, our patients. And so there are a number of definitions of the quality of care. The Institute of Medicine back in 1990 defined quality of care as the degree to which health services for individuals and populations, right, so that actually is a restatement of the slide before. I apologize for repeating that. But they followed this up, the Institute of Medicine did in 2001 in their landmark white paper, Crossing the Quality Chasm, of noting that quality care is safe, timely, effective, efficient, equitable, and patient-centered care. And so they came up with this clever acronym of STEEP to go with it. And the concept is getting the right care to the right patient at the right time and I would add at the right price. That's where efficiency comes in, and equitably as well. And that's really what we're looking for. So someone who's taken a good look at this in health services and healthcare is Don Abedian, and he developed this really rather clever way of thinking about the quality of care, really it having three main pillars to it. And unfortunately, I have these boxes and not pillars on this slide, but the concept is still there. So there are items or elements of a good structure of care that can promote quality, and these are things like our medical record system characteristics, our staffing characteristics, are the availability of diagnostic and therapeutic resources that an office has available, our phone systems, really anything that's sort of brick and mortar, and any of the people and technology that's brought to the clinical setting that's out there. And this is obviously something that's changing, as you guys well know, because it really used to be, to some extent, about the brick and mortar and the human beings that sat in offices and sat in call centers and interacted directly with you, our patients, and were convenient for you and us, our doctors, but not really so convenient. And that's why what we're really testing here is whether or not having, having the kinds of things that you have available on your phones and iPads, and now blessedly on your bigger screen computers, so that we don't just end up feeding our ophthalmology colleagues. You can take this with you. It's really not just about what's in our office. It's what's in the palm of your hand right now. So that's what structure of care is all about. And another key element for quality, either as part of its assessment or part of its improvement, are what we would call the processes of care. These are things like diagnostic tests themselves, preventive care processes, disease management processes. These are the things that we do to try and drive our improved outcomes of care. So are we checking certain things? And you saw on that list of, of sample checklist items that were there, all sorts of things about blood tests before starting a certain medicine, discussions about skin cancer that are relevant to certain medicines that we use, and whether or not these processes are being done, presumably to drive better outcomes. And then, of course, there are the outcomes of care, and these can be hard clinical outcomes in some illnesses. We'll use cancer as an example, either recurrence of cancer or remission of cancer. And certainly these are the kinds of things that we like to abstract as well into the IBD world. So is the disease active or isn't it? Are patients having surgery or not having surgery, missing work, not missing work? These kinds of outcomes that we'd like to measure. And then there are also the patient-reported outcomes, things that you guys can tell that we don't have to sort of measure on a scale, like on a blood test or on a literally a scale, like weight. And then resource utilization and dollars that we're spending and things that we're doing that we can count as well. And these are the outcomes of care that we want to improve. So that's sort of the what quality. And so then that really brings us to the question of why quality. And perhaps I should have started with the why, but the what until it was defined, I thought kind of made more sense. But the why quality is what's really important here too. And very often, sometimes at referral centers, sometimes even what gets sent to us, and sometimes what we ourselves do unwittingly, is we don't always provide a uniform and high level of care to all of our patients, though everyone is trying to. The concept here is that every patient with Crohn's disease, with ulcerative colitis, or really with any health condition, really ought to have a certain minimum standard of care that they have access to. And this is, I've likened this to raising the floor. So we want to be sure that everyone gets what they ought to get. So if patients keep getting steroids, then we need to start thinking about having someone on a steroid-sparing therapy by way of an example. And we want patients to really do as well as they can, and we want to minimize errors, we want to maximize safety, and we want to improve outcomes. And these are like the minimum or the things that everyone ought to have when they enter into this realm of a discussion of care with their physicians. And so then that gets us to the how, and how we go about ensuring quality, and what are the processes that we can undergo or undertake to guarantee or to at least improve the likelihood of getting high quality care. And so we'd like to enhance the structures and processes to improve the outcomes in the Donabedian fashion. There are also things that we can do with proactive measurement-driven processes, and you may have heard these, and these are used in other industrial engineering situations, and there's things like lean, and that's a derivation of the Toyota quality management process, and others that were used in Japanese car manufacturing. And the idea behind lean is to cut out waste wherever you can, things that are unnecessary, things that are potentially harmful, and there are 7 or so wastes that can be there with time and movement and energy and so on. So we want to minimize the amount of waste, maximize good things. And Six Sigma is a related but different process by which industrial engineers go about things. And that has more to do with reliability, making sure that we do the same thing over and over again with a great degree of fidelity and consistency. And it's derived from the concept that each 1 sigma is a standard deviation from the mean. And when you get out to something that is a 6 sigma process, your failure rate is, I don't know what the exact number is, but something akin to less than 0.001%. So that's a good thing. And these are these are kinds of engineering and process improvement systems that can be brought to bear to improve the quality of any system. And the idea here again is to drive out waste, drive out errors, and therefore drive out unwanted outcomes. And that's really the purpose. And oftentimes we go about these what are called PDSA cycles of quality improvement, and the P stands for plan. And that's when you go about and figure out what your objectives are, what you expect or how you can predict what's going to happen, and then you plan to carry out a cycle either in a small pilot or in a larger test environment and collect data to see how you're doing. And then you actually do it. You carry out the plan, you document your observations, you record the data that are there, and then you can go ahead and study and figure out, well, what could we do? Did we improve things here or not? You analyze the data, you compare your results to your predictions, you summarize what you learned, and then you can act on that. Well, what changes do we need to make, either to expand this to a larger group or to further improve what we have, and then you're off to your next cycle. And so we think of this as sort of a repetitive or an iterative PDSA cycle toward quality improvement in the desire with the notion that by taking continued turns around this cycle that you can slowly and steadily improve your processes and your actions to better guarantee or get to where you'd like to be in improving outcomes, or sometimes it's something as simple as improving a process. For you guys, and I apologize in advance as I bring this topic up, something we'd really like to do is to take the pain and the hurt away from you and just scheduling a colonoscopy if that's possible. And so what can we do? What can we do with our phone system? What can we do with our endoscopic schedulers? What can we do with our prep instructions? These are the kinds of things that in the sense of improving our fidelity or in our ability to repetitively make sure that there's a good interaction there. This is something that we can do, and that would be an example of an improvement project that we could undertake. So we're going to move back a little bit to those Donabedian process measures and think about outcome quality indicators as well. And I sort of glossed over it to begin with. A process quality measure would be a measurable healthcare action associated with good care. I kind of described this before and used that same example of steroid-sparing therapies. So in steroid-dependent or steroid-refractory patients, we want to be sure, and we are obliged to, and it's good care and it's high-quality care, to be sure that we have recommended and have a plan for a steroid-sparing agent to be brought to a patient who has either steroid dependence or steroid refractoriness, if that refractoriness business is in fact a word. Making sure that patients get colonoscopies if they're at high risk for the development of colon cancer, as some patients with long-standing Crohn's disease or ulcerative colitis are. And so you can measure how, how well and how timely you perform these kinds of colonoscopies, and you can actually write out these kinds of things so that they can be measurable. And then you go about measuring and see how you do, and then you have to figure out what you need, what the next steps are for improving that process if there are gaps that are there. So outcome quality indicators, as I mentioned before, these can be patient-reported outcomes. These can be cost-type outcomes, or these just can be sort of more hard, or what we call hard outcomes, such as remission, such as the need to, or the ability to go to work every day or go to school every day, and the kinds of things that we would really like as good outcomes. You can, one minus that is the bad outcome, so days lost to work, days lost to school, things like that. And cancer avoidance in the example of our colonoscopy example as well. So these are kinds of process measures and outcome measures as well that we can go about and see and measure and analyze and work our process improvement projects around. So some examples of success using quality indicators in medicine include things like diabetes care, where 5 studies have demonstrated in 5 outcome and 5 process measures that patients could improve over time, or that outcomes for patients could improve over time. In congestive heart failure, self-management and decision support resulted in a 56% reduction in hospitalization. And that's an example of what we're trying to assess with you guys. That's the promise of our HealthPROMISE app here that you guys have access to, is can that bit of self-management and self-reporting as well as decision support, can that improve your outcomes? And that's what we're hoping to find out. In asthma, self-management studies have shown mixed results. 6 have been positive, and 3, unfortunately, were negative studies, meaning that they showed no benefit. But, in a number of chronic disease models, we've been able to demonstrate that a look toward quality improvement steps has improved outcomes. And then, of course, there's the shining example of cystic fibrosis. And if you're looking for a really interesting read, Atul Gawande, who you may remember or may not remember, but he wrote a book that I'm sure a number of you have read called The Checklist Manifesto. It was very popular and available. It's still available, but it's very popular on all sorts of bestseller lists about 5 or 6 years ago. And he wrote a wonderful piece in The New Yorker probably about a decade ago now that if you're interested, you can search. It's called The Bell Curve, and it's Atul Gawande, G-A-W-A-N-D-E. And what he reported on was the great example of quality of care with cystic fibrosis. Cystic fibrosis, for those of you who don't know, is a genetic disorder that results in all sorts of lung infections and can have different manifestations as well, but was associated with a very, very short duration of life for those who are affected by it. Much smaller in its number of patients affected than Crohn's and colitis, and most of the care delivered to patients with cystic fibrosis is delivered at a number of Cystic Fibrosis Foundation centers. There are 115 centers previously that were accredited by the Cystic Fibrosis Foundation, and steps in their quality improvement process first resulted in defining their clinical microsystem. You want to think of this as sort of that structure of care business that I was talking about earlier. This defined who the patients were, the providers, because this is a genetic disorder and affects children. Parents, obviously, hugely important here as well. The dietitians and social workers, also important parts of the clinical microsystem. They then went and established their quality indicators to be sure that that they had something measurable. They ultimately landed on, after some trial and error, they landed on body mass index, so that's sort of a weight per height kind of measure. Forced vital capacity, which is how much, if you take a deep breath in and breathe out as hard as you possibly can, that is, if you measure that amount of flow and breath total, that's your forced vital capacity. And because this was a disease associated with with death, unfortunately, they measured mortality as well. And then they made a very bold and almost brave decision to have complete data transparency across their 115 centers, initially anonymized as sort of center A, B, C, D, and then ultimately they named names of where these centers were. They posted all of their results, good and bad, online, and then they kept doing continual improvement processes through all this, and improved things with their telephones. They improved things with choices of antibiotics, and they kept redefining and redefining and redefining, and ultimately they had unfortunately this didn't show it, but and I'm sorry for this because really the big news here is that there was an improvement of 1.1 years of life per year for the 10 years that this program was in place. So they ultimately got more than 10 years of improved life expectancy for patients with cystic fibrosis by going through these efforts, and really just a marvelous, marvelous example of how quality improvement can really assist and make dramatic changes in a chronic healthcare condition. So why do we need to think about quality of care for IBD? And I'm just going to go through a couple of really sort of simple examples, as some of this may even be one of you. But let's pretend that there's a 37-year-old woman with ulcerative colitis, and she receives about 6 courses of prednisone per year. She was never offered steroid-sparing therapy, and nor was she offered a bone density scan or DEXA scan to assess what kind of bone loss she may have had with all of that prednisone. In a second case, we've got a 41-year-old woman with a history of Crohn's disease of her colon, so colonic Crohn's disease with persistent symptoms of diarrhea despite trying maximum dose of all of the available or approved anti-TNF therapies for Crohn's disease. So that would be Remicade and Humira and Cimzia. And then a colonoscopy is done, and even though we know she has colon disease of her Crohn's, she had nothing but normal biopsies, so she really had terrific healing of her colon. And then let's imagine a 28-year-old man with Crohn's disease who undergoes an ileocolonic resection, so that's a kind of surgery where the last part of the small intestine and first part of the large intestine gets removed for active inflammatory disease. It turns out he was receiving a dose of azathioprine or Imuran at just 1 milligram per kilogram of body weight per day. So we'll pretend he weighed 75 kilograms, which is probably in the neighborhood of 170 pounds, and he was receiving, we'll just say, 175. So he was just receiving 175 milligrams of azathioprine or Imuran only. And that first example is an example of underuse of good care. And so this is a patient who really patient 1, that 37-year-old woman with the multiple prednisone courses, really needs to have a steroid-sparing therapy prescribed her way, and she ought not to just keep going with repeated doses of steroids without a plan to reduce and keep her off of those steroids. The second example is an example of overuse. So possibly, if not probably, that very first anti-TNF that she received, whichever one it was, and we'll just say Remicade for the sake of argument, though it could have been Humira or Cimzia, may have resulted in great healing, and in reality, her persistent symptoms may have been due to something other than active Crohn's disease, but without the colonoscopy and without the investigation to see how inflamed she was or wasn't, no one really could be sure. And so this would be an example of overuse. And then the third one, though it's a little more subtle, usually we like to dose Imuran or azathioprine at 2 or 2.5 milligrams per kilogram. And so this is somebody who should have been on 150 or 175 milligrams per day of azathioprine and not just the 75 milligrams per day that he was on. And so some would argue that this would be misuse. The whole idea of quality in terms of eliminating waste is to minimize underuse, minimize overuse, and minimize misuse. Though sadly we know, and I know and some of you all know, and hopefully I'm not responsible for any of it, but there is underuse, overuse, and misuse of really routine processes in IBD care. there's also a good amount of variability of care, and variability is kind of the enemy of high-quality medicine. And so I mentioned before that, we try, that whole sort of Six Sigma idea of doing everything in a very similar fashion and in a repeatable way is very important. And so a conglomerate really of a number of, or 10 centers of IBD pediatric care were analyzed by Mike Kappelman, a colleague of ours down at the University of North Carolina, and he found that thiopurine, and thiopurines are 6-MT and azathioprine-imuran, that and methotrexate really had a very, there was really a center-to-center difference in how they were prescribed. And as you can see all the way out on the right here, Center 5 used thiopurines or methotrexate in about 97% of their patients, whereas here at Center 3, it looks like only 29% of their patients were on thiopurines or methotrexate. And so a really big difference. You can see everybody else was sort of scattered somewhere in between. And, all of this center dependency is, sort of an interesting phenomenon that's there. We don't know, if the 97% is the right number or if the 29% or somewhere in between is the correct number and what we ought to be doing, but certainly other factors seem to be explaining this variation in care that's out there that probably have very little to do with the patient features themselves and have more to do probably with the traditions of that individual institution. So the idea is, well, what, can we get it so that each institution has a, near level or approximately similar rate based on guidelines and based on the development of proper quality indicators. There's insufficient adherence to guidelines, and this has been shown in a number of situations, but here's an example of insufficient adherence to guidelines in a number of different situations as were thought important back in 2003 and 2004 when this study was done, ultimately published in 2005. But you can see the rates at which certain processes were adhered to was really quite, was quite low in a number of situations. And so, there is insufficient adherence to a number of guidelines in the IBD world, unfortunately. And then there's also, sorry about this, I'm trying to get this done properly, and then there's also variation in colectomy rates for ulcerative colitis, which have been demonstrated to be, to be variable based on what race you have. So, so whites, as you can see, declined from about 15% colectomy rates over these years to about 8.5%, whereas African Americans or black individuals started at 6%, lowered down to 2%, and then up. And you can see this is the curve or the data points for Hispanic patients. But it's not just about race. Geography seems to matter as well, and you can see they're very different colectomy rates for ulcerative colitis based on whether you come from the north or whether you're seen in the Northeast, in the Midwest, in the South, or the West. Again, there's no judgment on any of this because we don't know what the right colectomy rate is for any of these patients or for, let alone for any one individual. But it's certainly curious that it's not applied uniformly according to race or according to geography. So do we need quality indicators in Crohn's and colitis? Absolutely. I think that it's pretty well established that there's variation in care, which is the enemy of quality. There is complexity of the management algorithms, and so there's too much opportunity. We didn't go into this in great detail, but there's too much opportunity for variation in care that's based on the complexity of these illnesses. There's the potential for improved patient outcomes, which is what all of us really want with new therapies, but we want to use them in the right patients in the right time. And you can substitute surgical therapy, medical therapy, dietary therapy, and so on down the line that's there. And we want, we want to get the right therapies to the right patients at the right time. There's been, I haven't shown you these data, but there's been quite a big increase in cost of care over time. Now, part of this is being driven by just changes in the healthcare system in general and the cost of pharmaceuticals, perhaps in particular. But with a rising cost, we all would like to keep costs down as best we can, but we want to take care of the individual right in front of us. And what we don't have, unfortunately, yet are a number of benchmarks to help drive performance that are here as well. and that's another part of the need for quality indicators. So there are already a handful of quality programs in the U.S. related to IBD care, including the ones that you guys are pioneers and are already enrolled in, which is very nice, and I want to thank you again for that. So one is a pediatric consortium called Improve Care Now, and this grew out of the conglomerate that I spoke about earlier that Dr. Kappelman had done the study on thiopurine and methotrexate use. And the group is called Improve Care Now, and I think you can go to either improvecarenow.com or improvecarenow.org. I'm not sure which, but if you just Google search Improve Care Now and say Crohn's or colitis, you'll be able to find it. And they have defined these outcome measures as the ones that they believe are worth chasing. And these process measures, and here you have a good example. So you have remission as defined by a physician's global assessment, steroid-free remission or number of days in steroid-free remission, sustained remission, patients off of prednisone, satisfactory nutrition and growth, remembering that this is a pediatric population. Growth becomes a meaningful indicator or can be viewed as a meaningful indicator. It turns out to be an important one. Then the process measures are whether or not patients got seen in the last 6 months, whether or not they had this blood test called TPMT, an enzyme test, before getting started on 6-MP or azathioprine, whether they had appropriate weight-based dosing of their Imuran or 6-MP, whether they had levels checked along the weight-based guideline, whether they had their PPD or tuberculosis status test prior to beginning infliximab, and so they started these, the Improve Care Now group started before Humira was even available, let alone Cimzia or Simponi, and so that would expand. And similarly, whether or not infliximab levels were checked according to guidelines, and whether methotrexate dosed was weight-based according to guideline as well. And so they've done this, and then here's what the output of these kinds of things are. And you can see how, and this represents one individual center, not the overall group of all the Improve Care Now centers that are signed up for this. And you can see how, how this group or how this center does, and whether or not they had their complete diagnostic evaluation, whether disease severity was appropriately documented, and this is an example of what you would call a ceiling measure. So the benchmark was above this green line here, and then you can see every measure at every point in time exceeded the benchmark, and it turns out this was happening at every center. And so there's no point in continuing to measure it. If everybody's doing it right all the time anyway, then that's not a particularly good measure. But where there's variability, you can see here about doses of sulfasalazine and mesalamine, rather, you can see that initially they were probably underdosing a bit, and probably through improvement efforts, this run chart shows that they were able to improve it, and mostly by the end of this time measure, they were able to exceed the benchmark in a handful of occasions, or almost every month of measure. So this is how we see how folks are doing over time. And you can look at an individual patient, as you guys can do on your output on your screen, and then we can aggregate those and see how individual physicians and or groups of physicians are performing. The Crohn's and Colitis Foundation of America also has a measure set that's out there. Some of the measures are the same, in part because there was overlap between the people who chose the measures, and I was fortunate to be part of this group of establishing these measures. And it's some of the same stuff about checking tuberculosis and hepatitis status before starting a Remicade or Humira-like medicine, trying to drive towards steroid sparing. So if no improvement on the inpatient side, if no improvement in 3 days on IV steroids, check for CMV status and ask a surgeon to see. That's one of our inpatient measures. And if on prednisone 10 or more for 16 weeks, people need to document that they've initiated a steroid-sparing therapy, whether or not we're checking for C. diff and so on. And I think, are we going to share these slides? Or they're going to? Yeah. So I'm not going to go over each and every one here because we're going to end up sharing these slides with you. But this is certainly an important, an important effort in finding our what we came up to be 9 measures that were there, and that was created by a RAND a RAND panel, which is a way of choosing things and having people vote in an iterative fashion and having multiple stakeholders, including patients, be a part of this. Then we have outcome measures as well. Sorry, I didn't mean to get up that high with the pointer. We have outcome measures as well, and steroid use, days per month or unit of time lost to school or work attributable to IBD, days in the hospital, days number of emergency room visits, proportion of patients with malnutrition or anemia, and those with disease-targeted health-related quality of life. We have good measures for that, and I think that that's embedded into your phones and iPads and the like, and whether or not they're using narcotics and whether they have nighttime bowel movements or leakage and incontinence as well. And so you can measure these as well, and we can go on and make these sort of the outcomes that we want to drive toward, and that's a way we can measure. And so there are a number of other things that are available as well. I'm sure some of you probably had the GI Buddy app that the CCFA put out. And Dr. Atresia, who I think spoke to you last month and is the primary investigator or principal investigator in what we're doing here, created. And it looks very similar to what you've got, where you can log symptoms, keep track of treatments, your dietary information, and some lifestyle activities as well. And a very popular app that's out there. And then what you guys had, this is, I don't know, this is maybe version 1.0 or 1.1, and that's Dr. Atresia up there, who only sometimes now wears bow ties. But, you know, we can measure quality of life and symptom scores. We have a checklist of care, as we've spoken about already, and, you know, whether or not you're going to the hospital or having to go to the emergency room, which we'd prefer to avoid, certainly. But, you know, this is, I'm sure, somewhat familiar to you, and measuring all of these things is how we can, you know, how we can determine how we're doing. And, you know, we've got these great quality of life measures that are out there, and this is the part of the short form IBD questionnaire, and, you know, how you're doing today on any one of these variables, and then aggregating all of that and all of us being in touch with one another. You know, when red flags go up, as this score of 7 here with the red is out there, and then you get to submit it to us. So, you know, this is really nice, and, you know, I get a provider level dashboard, or I'm starting to get these provider level dashboards, and, you know, we can find out how folks are doing over time. And the patient-centered outcomes, you know, are really where we're headed, where, you know, we don't have to necessarily measure things. It's, you know, you guys just sort of telling us, and these are things that you can just put right on, and we have put right on the apps now. So absence of pain, maintenance of continence, and so on down the line starts to look like a lot of the outcome measures that we were talking about that the CCFA came up with, and that's in part because we had a great group of patient champions who were part of that process. So just to briefly summarize, and then we'll get to questions and answers, and I will get to all of them, I hope, and I'll stay with you until we do. You know, there's a lot of variation that's out there, and it's usually an indicator of an opportunity for quality improvement. That certainly exists with Crohn's disease and ulcerative colitis. The quality improvement initiatives can be instituted in individual practices with the possibility of direct benefits to patients. And while we've gone elaborately on that, that's exactly what we're doing, what you guys are doing. So for the umpteenth time, thank you. And quality process indicator improvement, usually easier to achieve and over a shorter duration than getting quality outcome indicator improvement, but it's outcomes that we really want to, we really would like to focus on. And this whole business is really this continuous process of PDSA or some other kind of quality improvement or improvement project. You know, we're going to, just as the app keeps evolving and improving, you know, we'll have multiple projects. And, you know, what we ultimately measure in version 3.7 when we get there, whenever we get there, may look very different from what's on your handheld now. as we come to discover certain ceiling and floor measures that we may not need or may not want to improve, and as we're ultimately able to determine what the key triggers or measures that are associated with the really good outcomes that we want are. And so that's all I've got, and I want to thank you guys for listening, and just want to take questions now. So I think to do that, I want to close down this, and I think that's right. And now we're back up on the WebEx. So.
Hi, Dr. Ullman. I've just unmuted everyone's lines.
Oh, terrific. No one out there snoring, or no one that I can hear is snoring. So thank you. Do we have questions that are coming in? So I guess we have a couple. So one question that's coming is, how often should patients undergo screening when taking biologics? And this is sort of an interesting question, and one of which there's no definitive answer that's out there. So I can tell you to some extent what I like to do and what's in the package insert of some of these medications. And so we certainly like to do screening before anyone starts, and that screening includes hepatitis B, to be sure that there's no active or latent infection of hepatitis B, and similarly an accurate test for latent tuberculosis. And then the follow-up timing of that is once you've done the hepatitis B, it should become apparent for anyone who is maintained on any of these anti-TNFs. It would become apparent because there would be some blood test changes, so we continue to monitor bloods as our proxy for measuring the screening of hepatitis B. But there's some controversy around, or rather uncertainty, I should say, around tuberculosis. And it's advised that we measure once every year, but we don't necessarily need to do that because like hepatitis B, active tuberculosis infection in the setting of Remicade use or Humira use or Cimzia use or Simponi use, would and should become very clinically apparent to anyone. So I hope I haven't muddied the waters by saying that there's no one way here and that it's still a debatable point. But we do it once before we start. We need not necessarily do it periodically over time, even though it does suggest so on the package insert. So any other, sorry, we're gonna try and see if we can figure out where the questions might have gotten entered.
Yeah, absolutely. Yeah, that seems to be working. I think because Marshall did speak to it, yes.
Are there any other questions?
Yeah, right.
Hello? Oh, wait, here, I see one now. Do you need yearly colonoscopies while on long-term biologics? And so that's a great question as well. And so the biologics themselves don't necessarily confer any increased risk and may actually, in fact, though we don't have any information, there's a suggestion that by reducing inflammation, it's possible that they actually reduce the incidence of cancer. Now, we don't know that yet, but they really don't change what we do about cancer screening and surveillance in ulcerative colitis and in Crohn's disease. So the standard recommendation there is for anyone who has a third or more of their large intestine or colon involved that they get at every 1 to 2 year colonoscopy after they've had the disease for 8 years or more. If one happens to have both ulcerative colitis and sclerosing cholangitis, or Crohn's disease and sclerosing cholangitis, those patients get started on their screening and surveillance at year 1. We don't wait for 8 or more years to elapse. but it's not changed or impacted by the presence or absence of biologic therapies. Any other questions? Well, here we go. What are the guidelines regarding the use of biologics for those patients, usually from Europe, that were vaccinated with BCG vaccine and test PPD positive? Right. So in in Europe and in other parts of the world, BCG vaccination often happens, and so what we like to do with patients who have had BCG vaccination, because that can result in what's called a false positive PPD. What we do for that is we do a different kind of test called an interferon gamma release assay, and the most common ones of those that we can do are called quantiferon gold, and then we'll probably also do a screening chest x-ray to see if there's any evidence of prior tuberculosis infection, and that's usually more than adequate. Any other questions?
Dr. Ullman, this is
yes.
Ashish Fraser, and I first want to thank you for this webinar today. And often my patients ask, when is the best time to discuss about quality of care and the checklist? Should they wait for the next office visit, or they can correspond through my chart or phone encounters? So wondering, what is your practice and what would you recommend your patients?
Oh gosh, so I mean, I can tell you on a number of things.
Yeah.
Oh, that's wonderful.
So on a number of these different elements that can be checklisted and can be put into a checklist or a simple questionnaire, or as they are now embedded within the HealthPROMISE app, any time is fine. And really, what's most convenient for the patient is probably what ought to be done. I would love to tell you that, with my schedule, that my fidelity or ability to get all of these things done with each and every visit happens, but clearly, as those of you who are my patients on the line here know, it's not done that way. And so, I think that this is a great effort as sort of a tickler or reminder for all of us to get this done. But any of those avenues that you discussed, phone call, office visit, my chart message, they're all perfectly great ways to, to discuss or bring up any of these quality indicator items.
Okay, thank you. While you're waiting for more questions, I would like to remind all the patients that a survey for the HealthPROMISE will be coming soon to you, getting your feedback and about how satisfied you are with the app and any suggestions you have before they improve on the app. So please stay tuned for that in the next 2 weeks or so.
Yeah, that's true. It does show respect.
Yeah, it does.
All right. Well, thank you guys very much. I really enjoyed this, and I hope everyone has a great night tonight and that your team wins the NCAA basketball tournament. So hang on for a second.
I said to her the same thing. I said, that shows
we want to thank
you
each and everyone for coming to join us this evening for the webinar. I want to also thank Dr. Ullman for taking time to explain these quality indicators to us. Briefly, we want to say that there will be an upcoming survey. If you all remember, at the beginning of the study, we had said that after a specific period of time, we'll be sending out survey so that you could feel to tell us on how the app went and how the app usage went, and we will appreciate if you could fill those surveys and send them back to us. We'll also be expecting your feedback so that we could also make amends and make the app more better for us to use. Also, we want to let each and everyone know that our webinars will be in the first Monday of every month, and then we have upcoming series. So the next webinar will be on the 2nd of May, and there we'll be talking about the role of microbiome in IBD. So please stay tuned and check your email for our newsletter, And please note that the recording and slides for this evening will be sent in the next newsletter, so we'll be sending that to everyone. Thank you very much once again for joining us, and you all have a wonderful evening.
Plastic. Mm-mm.